We talked about intersectionality. So intersectionality, for those who are unfamiliar, is something that Kimberly Crenshaw came up with. Well, it wasn't coined by her, but it's popularized by her. The needs and issues of a particular population, in her case, it was Black women, were not being addressed. So the experience of, say, Black women in structural racism is different than that of, say, Black men in structural racism. And so that's what intersectionality is. There are populations that are visible in how we've defined who they are, but there are also populations that are intersectionally invisible. So when you're thinking about the partners that you engage with, and the people who are fundamental to those relationships, one of the key things is paying attention to who are those partners that are at the table, who's not at the table, what is unique about the population that you're talking about. So who we engage, how we engage, who has the power to decide what's on the agenda, what kinds of things are discussed, and who gets to make decisions about the distribution of resources. We need to look fundamentally using what's called a gender mainstreaming approach, which is basically saying one of the lenses that we should use is through the lens of gender and how that intersects with other things like race, ethnicity, and other factors. We need to look at how the experience is qualitatively different for those populations whose markers are things like gender and sex. The next is what kind of conceptual frameworks and models are you using to guide the work? Most of the models that we have for promoting health and well-being don't typically include some of these newer concepts that are now the fundamental drivers of these issues. One of the key parts that we have missed in the science that we've done thus far, that again is an opportunity, is what are those subgroups of populations that are missed by the way that we tend to present data as it stands right now? If you look at most of the data sets, most of the reports, we have a line that's basically for sex. We have male and female usually, and then we have another line that says race. What we rarely do is look at the intersection of sex and race and do not recognize the need for sexual orientation, gender identities that are fundamental to who people are and what they're bringing to the work. Again, not as markers of difference, but as markers of assets and things that need to be part of the ways that we do the science that we're trying to do.
And so part of addressing this question involves identifying particular facets of racism. And one of these facets or dimensions of racism is racial discrimination. Racial discrimination is the direct experience of being treated unfairly because of one's race. So others have looked at other types of data from the internet to capture underlying population attitudes. So for example, this is a map of social media data, specifically homophobic tweets. Tu Nguyen and colleagues conducted sentiment analysis on almost 1.25 million tweets. And she found that states with less positive racial sentiment towards communities of color, as indicated by these tweets, had a greater prevalence of low birth weight and preterm birth. So this type of racial residential segregation has been linked to negative health outcomes. So for example, this recent systematic review found that Black mothers living in areas characterized by greater racial segregation and in particular racial isolation were at higher risk for having adverse birth outcomes. And we found significant associations with these adverse birth outcomes, preterm birth and low birth weight among Black mothers. So again, this biological embedding of racism may be a common underlying factor associated with racial inequities across multiple diseases. This includes one particular disease that's been the focus of my work, and that's systemic lupus erythematosus, or lupus for short. For those of you who aren't familiar with lupus, lupus is a chronic inflammatory autoimmune disease characterized by a range of symptoms and several comorbid conditions. The epidemiology of lupus is characterized by major differences in prevalence along both gender and racial lines. Women represent about 90% of new lupus diagnoses. And among women, Black women have about 3 to 4 times the incidence compared to white women. But beyond these differences in prevalence, we see that once diagnosed with lupus, Black women have greater disease severity and faster disease progression, having worse outcomes compared to white women with the same disease. And the reasons for these disparities are traceable to underlying social inequities. There's very little evidence for any biologic reason for these disparities. So, Black Americans, and in particular, Black women, have been bearing the weight of multiple pandemics.
For example, if I tell you COVID is going to happen, before COVID happened, I could have, predicted, okay, well, certain groups whose markers are things like race and ethnicity are more likely to have a higher rate of mortality from COVID. Not surprisingly, that's of course what happened.
We looked at Black women's experiences during the COVID-19 pandemic. We looked at experiences of racism, in addition to COVID-specific experiences. So this included knowing someone diagnosed with COVID, knowing someone who died from COVID, as well as themselves getting COVID. We looked at their experiences of work and economic disruption. So this included experiences of unemployment, reduced working hours, things like loss of income. And what did we find? We actually found that Black women in our study were highly resilient in the face of these multiple co-occurring public health crises. Compared to whites who experienced similar levels of these health threats, Black participants fared better. They handled or coped with these experiences better, which I think counters dominant public health narratives about who is quote unquote vulnerable. Black women experience more health harms because they are more likely to bear the constellation of these three public health crises. And as a result of this, the Black women in our study reported higher levels of stress, as well as depression and anxiety.
And then another environmental factor that I just want to name is homelessness. When you look around the country at our major urban areas, this lack of wealth and this lack of access to income and opportunity translates often for Black families into also not having housing security. For instance, in San Francisco, you can see that nearly a quarter of Black pregnant people did not have a place to sleep during pregnancy. And that's not compared to a white average, but rather an overall San Francisco average of only around 3%. The next criteria in the racism as a root cause approach is that our interventions need to be precise. And by that, I mean that we need to recognize that while all people of color experience racism, we don't all experience racism in the same ways. For instance, the ways in which a Vietnamese immigrant might be experiencing racism is going to look very different than the ways in which an African American whose family has been in this country for centuries is experiencing racism. For instance, your race determines your safety. There is a 1 in 1,000 risk of being killed by a police officer in this country if you're a Black man. And you can see by this slide that your safety when confronting a police officer is very much determined by your race in this country. And so if we use a one-size-fits-all approach, we're not actually going to be able to get at the specific racial barriers that a given group is facing. And so therefore, it's going to really limit the efficacy of our intervention.